Welcome, everyone. In today's lecture, we're going to connect how we think about health, that is, our underlying models of health and disease, to how we actually engage with families, patients, and communities, and how we advocate for better care and more just systems. By the end of this session, you should be able to explain how biomedical, biopsychosocial, holistic, and integrative models shape health engagement and advocacy. Identify key communication principles for patient centered, coordinated, and collaborative care. Apply health communication theories, especially behavior change and media effects, to advocacy. And lastly, use critical, cultural, narrative, and humanist approaches to design more just, person centered health communication. So, why do models matter for engagement and advocacy? When we talk about health engagement and advocacy, we're always answering implicitly what counts as a health problem, what counts as a valid solution, whose voice is central. Your answers depend on the model of health. In a biomedical model, engagement focuses on diagnosis, treatment adherence, and procedures. In a biopsychosocial model, you also attend to stress, coping, family, stigma, and social support. So these models will look at how social justice is embedded in our healthcare approach and outcomes. In holistic or integrative models, you engage people around meaning, purpose, relationships, and daily functioning. If we are not intentional, we default to a narrow biomedical view led by institutional voices. Our goal in this course is to expand that and make engagement and advocacy more equitable and person centered. Let's go from the biomedical to biopsychosocial engagement. The biomedical model is powerful and necessary, but it narrows engagement to symptoms, diagnosis, and treatment adherence. A nurse might say, "Take this twice a day and come back in 2 weeks." Advocacy might focus on access to a specific drug or test. The biopsychosocial model expands this to the social and psychological domains alongside biological in medical decision making. It includes the biological perspective, which focuses on disease process, physiology, and lab values. On the psychosocial facets, which include beliefs, emotions, fears, coping styles, and self-efficacy. And on the social perspectives, which include family, culture, income, work, discrimination, and community resources. For example, with a patient managing diabetes, a biopsychosocial approach asks, "How do you feel about this diagnosis? Who helps with meals or shopping? What makes it hard to follow this plan in your daily life? How is stress affecting your choices?" Advocacy then extends beyond the prescription to food access, safe spaces to move, mental health support, and policy change. Holistic and integrative models. The holistic model emphasizes multiple dimensions of wellness. These include intellectual, social, spiritual, physical, mental, and emotional. They take into account questions like, what gives your life meaning? How are your relationships and community supporting or straining your health? Integrative medicine combines these perspectives. They look at evidence-based biomedical care, the biopsychosocial context, and they give a holistic attention to the meaning and daily life purpose. In integrative engagement, we present both conventional and evidence-informed complementary options. We invite patients and families to share what feels acceptable and aligned with their values. We co-create plans that might include medication, counseling, stress reduction, physical activity, and culturally meaningful practices. So advocacy here is about building systems that support whole person health and making meaning such that this care is accessible to diverse communities and not just the privileged. Let's look at the health communication theories and models. Health communication is a social process that responds to health concerns with timely, accurate, and culturally sensitive communication. It covers a range of topics from disease control and prevention to workplace safety and health. It seeks to understand how messages relating to healthcare processes and delivery are created, sent, and received. And it covers myriad contexts, including patient experience, patient-provider communication, healthcare team communication, provider communication, media and new technologies, mental health, crisis communication, and a host of other topics. In this case, if you remember, whole person perspective to health also attends to patient-centered care and coordination of care. This means that patient-centered care is at the core of health engagement and advocacy. It involves treating patients as experts in their own lives, not just as cases, respecting their values, preferences, and goals, even when these are different from ours. Communicating in ways that are understandable, respectful, and responsive. Patient-centered engagement includes questions like, what matters most to you as we think about treatment options? How does this plan fit with your work, caregiving, or financial situation? What are your concerns or questions that we haven't talked about yet? As an advocate, you help ensure that systems and teams are truly organized around what matters to the patient, not only around what is prioritized by the institution. When we think about coordination of care and team communication, engagement and advocacy are also deeply embedded. We ask questions like, are patients hearing consistent messages from nurses, physicians, therapists, and social workers? Are transitions, whether it's from hospital to home or between specialists, communicated clearly? Does someone help the patient and family navigate follow-up, medications, and resources? As a nurse, health professional, or communicator, advocacy includes clarifying confusing or conflicting information, sharing the patient's priorities and constraints with the team, ensuring that communication between professionals does not happen around the patient but with the patient. Likewise, consider collaborative and shared decision-making as key to the whole person approach. And this might involve presenting options, benefits, and risks clearly and honestly, acknowledging uncertainties, exploring the patient's values, fears, and practical realities, and reaching a decision together. This is different from simply telling patients what to do. It sounds like, here are the main options. Let me explain what we know and don't know about each. Or, given your goals and your situation, Which option feels like the best fit for you? Or what support would you need to make this choice work? Advocacy here means protecting the patient's right to be informed and ask questions and to say no. So, with that little detour, let's look at the theories of health communication and start with the behavior change theories as engagement tools. These theories are useful for designing engagement and advocacy strategies. They highlight intention. Does the person want or plan to do the behavior? Skills and abilities. Do they know how and do they feel able to do so? The environment. Does their content support or block the behavior? They also emphasize attitudes. Do I believe this behavior is beneficial or harmful? Social norms. Do people like me to do this? Like me do this? Self-efficacy. Do I believe I can do this given my life circumstances? Instead of labeling people non-compliant, an engagement mindset will ask, what attitudes, norms, or barriers are shaping their behavior? How can we help build self-efficacy, for example, by breaking changes into small, achievable steps? What environmental changes like transportation support, flexible hours, or financial assistance could help make healthy choices more realistic? Effective advocacy makes it easier, not harder, for people to act on their intentions. Before we get to the critical, cultural, and narrative approaches to health, let's take a quick detour into media effects and agenda setting in health advocacy. Media effects theories help us understand how health messages spread and gain influence. In this case, we have two key ideas. One is agenda setting and one is multi-step flow. Agenda setting looks at how media and powerful institutions influence what people think is important by the topics they highlight. The multi-step flow looks at says that messages often pass through opinion leaders, clinicians, community health workers, pastors, social media influencers, and so on before reaching broader audiences. As nurses, health professionals, or communication specialists, you may become those opinion leaders when you share accurate, compassionate health information online, or speak in community settings, or educate family and friends. When you do any of these, you're shaping the health agenda. Which issues feel urgent and whose experiences are visible, and which solutions seem credible? Advocacy here includes pushing for accurate, timely, and culturally sensitive coverage, correcting misinformation respectfully, and amplifying underrepresented voices. Having said that, let's look at critical, cultural, and narrative approaches to health. Critical approaches focus on power and equity. They ask tough questions like whose values and interests are built into our health messages and policies, who benefits, and who is harmed or ignored. How do our words and images reinforce or challenge racism, sexism, classism, ableism, and other hierarchies? For example, in a major drug ad, or for example, any kind of a health campaign that may be happening during the World Cup, Super Bowl, or other events, we might ask which bodies are shown as healthy or desirable, which communities are invisible. In this way, they eschew the top-down approach to knowledge dissemination and take a nuanced view of culture. And they examine how the use of language and discourse sustains or perpetuates health inequities. As advocates, critical approaches push us to go beyond raising awareness towards addressing the systems that create and maintain health inequities. So they attend to structural causes. Now, critical cultural approaches remind us that health and illness are also cultural and political constructions. Culture shapes how people understand the body, pain, mental health, disability, and death. It shapes what counts as normal or abnormal, which treatments are considered legitimate or unacceptable or illegitimate. Power determines whose cultural understandings get labeled scientific or rational. For health engagement and advocacy, this means that listening deeply to communities such as Indigenous, Black, immigrant, LGBTQ, disabled, and others, recognizing them as knowledge holders, not just as targets of education. It means moving beyond surface level cultural competence towards shared decision making and co created solutions. And it means challenging policies and practices that systematically disadvantage particular groups. Advocacy is not only speaking for people, it is creating conditions where they can speak and act for themselves with real power. Narrative approaches look at the story as a way of engagement. They start with the idea that humans understand the world through stories. Patients, families, providers, and media all tell health stories. It could be illness as battle, journey, test, or loss, for example. Health systems as safe havens or as threatening bureaucracies. Certain groups as responsible, resilient, or conversely as burdens. This approach has two main concepts. One is narrative coherence. Does the story make sense and hang together? The second is narrative fidelity. How does the story ring? Does it ring true to the listener's experiences and values? Stories can turn abstract data into concrete, relatable experiences, invite empathy and perspective taking, and expose injustice and mobilize action. However, they can also reinforce stereotypes and stigma, hide structural causes by focusing only on individual choices. Therefore, effective engagement and advocacy center stories from those most affected with consent and care. Pair powerful narratives with accurate information and structural analysis. And use stories to humanize and complexify, not to diminish people into single identities and narratives. These approaches have been embraced as empowering and incorporating nuance and person-centered perspectives in complex contexts. We should be aware of the power of narratives to harm alongside being aware of the power of narratives to resist and undermine healing and resilience. Rhetorical and humanistic approaches to health and medicine. The rhetoric of health and medicine looks at how language, metaphors, documents, and routines shape what medicine is and how it feels. For example, it examines metaphors like battling cancer or fighting a virus. It looks at how people's and the charts, medical chart notes, consent forms, and discharge instructions position patients either as partners, as risks, or as problems. It looks at how interprofessional communication can either empower or silence nurses, patients, and their families. Medical and health humanities bring in literature, art, and philosophy to reflect on suffering, moral distress, or joy in practice. They look at cultivating empathy and ethical imagination. And they look at recentering the human experience of illness and care. For engagement and advocacy, humanistic approaches mean arguing for systems that value time to listen, reflect, and connect, that recognize narrative and reflection as legitimate ways of knowing, and that help you see your own vulnerability and humanity as part of your professional strength and not as a weakness. Let us bring it all together. Think about your role as a health advocate. Whether you're training in communication, nursing, or health sciences, you will be engaging patients, families, colleagues, or communities in conversations about health. And you will be advocating, formally or informally, for better care, fairer policies, or more inclusive practices. Ask yourself, which model of health do I default to most often? Biomedical, biopsychosocial, holistic, or integrative? And how do my everyday communication habits, such as my questions, my explanations, and my listening, reflect that model? Ask yourself, where can I bring in critical cultural narrative and humanistic perspectives to make my engagement more just and person-centered? Think about what might be 3 key takeaways from the models for representing health and disease that resonated with you. How will you engage them with your community? Write down or think about one real or anticipated situation where you will need to engage or advocate. Identify the model of health that you are using to operate in that situation. Sketch 2 or 3 specific communication processes that you could employ to better embody whole person, culturally aware, and justice oriented engagement. We'll continue these through our lab work, quiz, and reading reviews. Thank you for your attention and for the care you bring to health engagement and advocacy.